Okay, so the first thing is I want you to take a little afternoon nap, and I want you to dream that you're somewhere else in Africa, outside of South Africa. In other words, healthcare is not a constitutional right. It is not protected by law. So maybe government says that healthcare is a right, but there's no way to enforce that. The second thing is, oh yeah, thank you. The second thing is that there's no concept of free care. In other words, you will pay for care prior to receiving care. Not only that, but there's no medication in the hospital. So if you go to the hospital with your tension pneumothorax, one of your family members need to go to a pharmacy outside of the grounds of the facility and negotiate the price of the IV cannula that will be used to decompress your chest. So this might take a half an hour, 45 minutes, 2 hours. You know, you might survive, might not. Take the family with. The third thing that you need to think about is there is no out-of-hospital care system. There's no paramedics, there is no ambulance, and there's no infrastructure. So the roads, non-existent. So you could go to hospital in an ox wagon with half of your family so that they can negotiate the care and pay for the care, and there is no constitutional right. Okay, so that's where you are right at this moment. And now we can go on to a little economics lesson, and that is there's no free lunch. So you guys all thought or think that you had free lunch this afternoon? Not true. You're sitting here the whole day. You made a trade-off. So the basic is that we all have a lot of things that we want. It's unlimited, the things that we want. But unfortunately, our resources to pay for that is limited. Sometimes it's fairly easy or superficial. You might prioritize having cappuccino every morning at say 20 to 30 Rand, but you say that you can't afford a gym membership. Actually, you can. Just cut the cappuccino. Okay? Or you might say that you're a smoker and you can't go to gym. Gym's quite an important thing in my life, so I just always use gym as that. So you could say that you're a smoker and you can't afford going to gym, going to the movies, but you actually are. It's a trade-off that you're making. So as soon as we don't have enough resources to pay for what we want, we are making a trade-off. That trade-off might not be rational to anybody else, but it's rational to us. And it's based on what we value. It's based on what we think is important. And it is based on what we perceive the benefit to be. So this was all easy stuff. So what happens to the patient in Africa, in the rest of Africa, where healthcare is not a constitutional right, where there is no out-of-hospital care, where there is no infrastructure, is they need to make a trade-off. And that trade-off can be massive. And they need to make that trade-off based on the perceived benefit. So basically, if we look at this, see if the laser works, the first thing is they have their income or their assets, which is basically their ability to get money to pay for the care. This could be selling a house, selling livestock, selling a child. We'll get to that. The second thing is the benefit. So is there any benefit in traveling 2 days with a tension pneumothorax to hospital? Probably not. Even just something as simple as a femur fracture. Taking 2 days to get to care, chances that you're going to survive? What about 70% burns? Would you risk it? Would you say that you're definitely going to survive that? Let's travel 2 days, sell our house, so that somebody in the family can survive? So basically, whether you're going to access care is dependent on the trade-off that you're going to be required to make. So in the rest of Africa, in poorly developed emergency care systems, the benefit is uncertain. Actually, I think for most of us here, we'll think that the benefit of accessing emergency care is actually non-existent. But what we do know is that the trade-off, that there's firstly going to be a high number of trade-offs, and secondly, that the trade-offs are certain. There's just no ways that you're just accessing care. So accessing emergency care in the rest of Africa is high risk, high stakes. It's a gamble. So some of the trade-offs, and before you think that I thumbsuck the trade-offs, these are trade-offs found in literature. So basically asking people, what did you give up to pay for care? So people sell their houses to access care. People basically decide, okay, I'm going to access it. I'm going to borrow money from everywhere, sell whatever I can, so that they end up in financial ruin after going to hospital for 2 hours, 3 hours, maybe a day. People might reduce their food consumption. So, cut this 3 meal a day thing, only 1 meal a day. Or maybe 1 meal every second day. People might sell a girl child into underage marriage, which is acceptable in some countries, and they reckon the ages at which they start selling the girls are 8 to 12. So you can sell your 8-year-old child so that somebody else in the family can access care. Prioritize one sick child over another, because if you have 2 children, they're equally sick, both of them need to go to hospital, and you can only afford to pay for one child, you need to pick a child. Okay? Or nobody goes. Or you might lose your job. So also in South Africa, we have a Basic Employment Act. So people are protected. Most people are protected. They can go to hospital, they can get sick leave. Maybe the boss will moan a little bit, maybe they'll pay them a little bit less, but they can still get paid. In the rest of Africa, if you don't go to work, you can lose your job. That's it. Not only lose your job, but lose your day's wage. So it's quite a trade-off to say go and sit at the clinic for 8 hours and wait for your care. They can sell their livestock. Okay, and sometimes that livestock is their means of income. And finally, they can decide not to access care. They can say, these trade-offs are too much, I'm not going to access care. I've got chest pain, 10 out of 10, I am sweaty, I'm pale, I feel like I'm going to die, but you know what? It's actually too much of a trade-off to go to care. And unfortunately, we have no way of capturing how many people decide not to access care. The other thing is that theoretically or statistically, they say, the World Health Organization says 25 million Africans will be pushed into poverty this year or every year because of the cost of healthcare. None of these trade-offs that I mentioned here is part of that statistics. So actually the correct term that they should use is to say a minimum of 25 million Africans will be pushed into poverty this year. So it's a gamble. For people to decide to go to access care in Africa is a gamble. And we're very lucky, those of us that are from South Africa, that has lived and worked and accessed the healthcare system in South Africa. And you might sit here and think, wow, you want to develop emergency care in Africa. You want to talk about it. So how can we do it? Well, the first thing is, there's 3 rules. The first rule is never assume a shared reality with the rest of Africa. It's different countries, different legislations. The legislation where you grow up is what you believe is normal. The way where you grow up is what you assume to be normal. Secondly, never assume to know the trade-offs. Cost of care is based on your values and based on what you perceive the benefit to be. You can't know how somebody else perceived that. And I think a really good example for me was a few years ago in Zambia. We were teaching IFA, that I'll talk about now, and we were actually teaching healthcare providers, and we were teaching them burns. So how do we treat burns? Running tap water, any of you heard that before? Awesome. What if you don't have running tap water in your facility? What if you don't have water in your facility? How do you treat burns now? So somebody else that was with me said burn shield. And I was like, if you don't have running tap water in the facility, the chances that you're going to have a luxury item like a burn shield, non-existent. So how do you treat it? We don't know. We don't know people's reality. We don't know their trade-offs. So finally, and that's rule 1, if you were following my numbering, involve the locals. So if you want to develop care, and if we want to have systems that are working, we need to involve the locals. So one way that we can do this is by emergency first aid responders, or EFAR systems. So what EFAR basically does is better outcomes, which basically increase the benefit. So you might sit here and think, how did I get to that? So there has been a few studies on EFAR systems, and the one study that I'm going to mention is Cambodia, which is not part of Africa, but they actually followed the EFAR program there for over 8 years, and they found that mortality dropped from 24% to below 10%. So it increases the benefit, better patient outcomes. Secondly, it reduces the trade-offs. It reduces the uncertainty, because part of EFAR systems is also to get patients to hospital and to get care to the patients earlier. So it reduces that uncertainty. And just think about it, sometimes what saves the patient is just keeping the airway open. If you know how to keep the airway open, you can get the patient to hospital, definitive care. And it's normally community owned. We try to give it to a community, and we try to make it context specific, which means what do they see in their community, what do they need in their community. And here we have to be careful not to employ our South African thinking maybe, or even American, westernized thinking, of we want to have an auditing system, we want to have a very set curriculum, people need to pass tests, etc. If you look at this little picture that I've got, this was in Kasama in Zambia, so it's 850 kilometers north from Lusaka. On the way there, we passed 10 MVAs. Okay. There is no pre-hospital services there. One of the MVAs was a bus that crashed into a small village, so quite a few patients, etc. But what's important here in the class is that about half of the class did not make matric. So are we going to say that they can't help their community because they can't write? So we need to change, and we need to make it context specifically. So EFAR, community trained first aiders, it's cheap to train people, it's easy to implement, it's sustainable. I put there in brackets in theory because it has been difficult for us to actually sustain it over a period of years. Some of the difficulties, communication devices. Other difficulties is we've been trying to get people to keep data, but there's no printer. So when they run out of paper, they don't keep any further data. They've also had issues basically training people up. And then basically long-term, cost-effective, cost-effective, context-specific, and as the formal system grows, we can basically incorporate it then with a formal system. This is definitely a much easier and better way to go than training a specialist emergency physician. That's going to be the one emergency physician with 13, 14 million people. So this is what we need to do, to basically train people in Africa or to take emergency care to Africa to increase the access of emergency care. And I keep clicking the wrong button. So thank you. That was me. Any questions?